Um, Hello, everybody. Thank you for joining us today. My name is Khalid Ali. I'm a third-year resident here in Chicago. I'm one of the coordinators at ABCDE, especially for the cardiology chapter. We have a session today, and we have our moderator, Dr. Ahmed Ismail, he's an assistant lecturer in Cairo University Hospital, and he's gonna present the case today. And we have great panelists from cardiology here in the USA, and some of them has already joined, and we'll wait for the other to join us while we're going ahead. We have Dr. Abuzey joining and Dr. Ghazali already here. Um, I just have to do a couple announcements before starting. This session is gonna be held every other month, and we mostly get cases from Egypt. And with collaboration with our coordinators from there. It's mostly Cairo University hospitals, but we are open to get from other places in Egypt and other university campuses and even other hospitals. And also we're still having the grant open, like donations for the grant for the residency match. We have right now we have 16K, and our goal is like 30K. So I hope if there's some body can share, and I'll let other people know. And if you can help us and donate as much as you can to help us help our rising residents in the USA. Um, Mostly of the part of the discussion will be run by Dr. Ahmed Ali, who is a cardiology fellow here in CMC in West Virginia. And Dr. Ahmed, you can start ahead.
He's muted.
مش سامعين كده الصوت بقى؟
Yes.
تمام، شكرا كده على المقدمة ديت، ويعني شكرا جزيلا لكل المحاضرين. وأحب أشكر الدكتور محمد سامي على وجوده معانا، يعني قطع أسئلة. في كمان الدكتور أحمد العشري، he is our program director، يعني لازم نتعود نكون موجود معانا في our analyst here as well. فإن شاء الله يعني too much echo. أنا هقعد معايا مش صعب معلش. لسه في ايكو دلوقتي ولا؟
لسه شوية.
تمام. طيب هو ممكن خالد يكمل، انا هغير المايك سريعا واجيب تاني.
I think we can go ahead and Dr. Ismail can start the presentation, and when he finishes, we can start discussion with our panelists.
Okay. Good afternoon, everyone. I'm Ahmed Ismail Salama, cardiology specialist, and had the pleasure to be here with you. I'm going to start my presentation, which is named Tale of Two Pressures, Causation or Mere Coincidence. Let's start. I got no disclosure. Our patient is 19-year-old female patient. She is married with one offspring. She is a housewife with no special habits of medical importance. She had hypertension for 1 year duration, and she had free surgical history. The patient condition started in childhood, where the patient started experiencing episodic attacks of headache. She would administer analgesics. And afterwards, during her pregnancy a year ago, she was diagnosed to have gestational hypertension. Her delivery was uneventful, and post-delivery hypertension was persistent. It was associated with shortness of breast functional NIHA class 2. She is the daughter of non-consanguineous marriage, and she had no other relevant family history. The patient main complaint with a recurrent episode of headaches of 1 year duration. On her examination, she had no orthopnea or PNDs or cough or hemolysis or fever. no syncope, no symptoms suggestive of other system affection. On general examination, the patient was only notable finding that her pulse, the blood pressure was different on both sides, and here she had a notable variation in her blood pressure between her upper and lower limbs. Her blood pressure was 160 over 100 on the right side, and on the left side, she had blood pressure of 150 over 90 millimeter mercury. On the lower limbs, she had also a blood pressure of 120 over 80 millimeter mercury on both lower limbs. She had a general examination showing was non-specific, and abdominal examination only, and chest examination was normal. And cardiac examination and by auscultation also no specific finding were apparent. So we got a 19-year-old female patient. She had hypertension. The only specific finding in her examination was notable radiofemoral delay, when we appreciate pulsating both femoral and radial pulsation. She had a notable delay in pulsation of the femoral pulsation, which mostly significant for notable aortic coarctation. Here we can appreciate her EKG. EKG was striking we could appreciate that the patient's sinus, her rhythm is sinus rhythm, and she had RVH with strain pattern, which suggests the patient has significant RV pressure overload. And that's her chest X-ray, and here we can appreciate that we got a prominent aortic knuckle. And if we could a little bit, I don't know if it's clear or not, we can appreciate that we got rib notching on the second and third space and third ribs. We got a notable rib notching. Her labs with normal, only proPNP and troponin also with normal. And here the patient had significant coarctation. The only apparent thing till now was the radiofemoral delay and in her examination, and the difference between upper and lower pulse pressure. So let's see the patient. We did here the first thing in examination. We do an echocardiogram, and here we start our segmental analysis. We presume that the patient had congenital heart disease, or that's our usual standard of routine in assessing patient like that. Here we can, in the subcostal view, we got our situs, and here's the situs solitus. And next thing, we got the IVC, and here we got notable normal flow across the IVC. The IVC is normally draining into the right atrium, no interrupted IVC or something like that. And also in the subcostal view, we're trying to exclude if there is any shunt or something like that by 2D and color Doppler. And here in the first panel, we can notice that our septum is intact. And in the modified, something like bicaval view, which we got from the TE, we get something like that in our transthoracic echo. And here we can appreciate that the septum is intact, and color Doppler show we know in color flow across the septum. And this is the bicaval view, which is analog to the bicaval we got in TE. And here we got a clear, nice flow of the SVC and the IVC, no color flow across the intra-atrial septum. Next thing, we got to our abdominal aorta. First thing, we noted the pulsatility and the size. What is the normal and what is the abnormal? Let's see what is normal first. In healthy individual without obstruction, pulsed wave Doppler, the abdominal aorta showed short deceleration time followed by brief early diastolic flow reversal and little antegrade flow through the diastole, which corresponding to the aortic elasticity of the aorta. The presence of coarctation caused delay, significant delay. We can appreciate if we got our ECG attached more than 50 milliseconds from the EKG R wave and reduction of the upstroke velocity with antegrade diastolic flow persistence, which we call diastolic tail, and loss of early diastolic flow reversal. And second, we got prolonged diastolic flow and reduced peak systolic velocity. This is our sensitive indicators of aortic obstruction. This is the flow pattern in the abdominal aorta. This is first one on the left. This is a normal upstroke flow. Second one, we got our diastolic flow reversal. We noted that if we got a significant aortic incompetence or if we got a PDA. Third one, that's a coarctation looks like in the pulsed wave Doppler. We got a slow upstroke and persistence of diastolic flow, or what we call diastolic tail. And sometimes we noted a steep narrow upstroke in cases like severe EMR. Back to our patient. First, a notable thing that the patient has significant reduction in the size itself of the abdominal aorta. It was 0.8 to percentile the E score. This patient has what we can call a hypoplastic abdominal aorta. And second thing, pulsed wave Doppler through the abdominal aorta of this patient, we got very delayed upstroke and persistent of the flow through the whole diastole. What we got here we got a nice diastolic tail, significant for aortic coarctation. Let's turn back to the parasternal long axis. Here, the parasternal long axis shows normal LV dimension and normal systolic function. No significant valvular regurgitation across the mitral or the aortic valve, but we can appreciate that the RV looks like that it's dilated and compressing the LV.
Did we lose him, guys?
I think so, yeah.
Yeah, I think so. Mhm. Mhm. Mhm.
هو أنا اللي عندي مشكلة بس ولا هو مش موجود ولا إيه؟
I think he has a problem with the connection or something.
آه.
I'm reaching out to them.
احنا هنحاول نكلمه دلوقتي، ثواني بس.
He's trying to join again. We'll just have to wait 1 minute or something.
While we're waiting, Dr. Ahmed or Dr. Khalid, what's the format that you guys typically follow in these meetings? يعني after the presentation conversations ولا you just want to go through as many presentations as you can?
Hello there. I'm sorry I got my connection back.
هو سريعا بس عشان نجاوب على الدكتور أحمد العشري. هو النظام بتاعنا هو البريزنتر بيخلص المحاضرة بتاعته الأول، وبعد كده الباناليست بيتناقشوا معانا في الفايندنجز أو لو في أي أسئلة، والحاضرين معانا لو في أي أسئلة بنجاوب عليها.
شكرا.
Can I continue?
Yes, you can go ahead.
Okay. Let's go back to our apical four chamber. This is apical four chamber, and we can notice that we got a markedly hugely dilated right ventricle with marked trabeculation. The RV to LV basal size is more than 1.1, and the LV seems too little, which was expected for a case like that, and heavy trabeculation in the RV. Next, we were searching for if we got intracardiac shunt or extracardiac shunt. And the RV dimensions were markedly dilated. The function was fair, not impaired. And we got our parameter, the tricuspid velocity max from the tricuspid regurgitation was 4.3. The E over E prime was a little elevated. It was 22, and left atrial index volume was 50.2 milli per meter squared, which a little bit increased. So let's turn back to our suprasternal view. And here in the left suprasternal view, you can appreciate that we got left-sided aortic arch, but in the descending part, we got noted that it's notably side is severely affected. We can note that there is almost no flow. And color Doppler showing a nice demonstration here. The color is red, which is again as the normal flow, which is supposed to be blue. Here the can appreciate that signifies almost we can see something like that. In total obstruction, if or in cases we got a total obstruction with collateral flow, we see reversal of the flow coming from the collaterals, and the descending flow seems severely diminished side of the descending aorta. And here we got a little flow beside a short segment which seemed to be stenotic, and afterward we got a blue color which seems to the flow of what appears to be a collaterals. So we got a short segment of aortic narrowing, or what we call obstruction, after the subclavian branch, and continuous Doppler, we assess these segments through gradients. First thing, our gradient was 40 millimeter mercury, and we got diastolic tail noticed by continuous wave Doppler. Next thing, we got to our crab view, if there is something like total anomalous or something like that, but we got, this is what normal crab view looks like, and we got normal pulmonary venous drainage. Something we need to make sure of if this patient has aortic coarctation, aortic intracardiac shunt or not. This is how we make sure of it. We insert our IV cannula with 3-way stopcock and 10 millimeter syringe with normal saline, and extension is needed. And let's see what it looks like. And here we can do it in the apical foot chamber or in the subpostal view. We do it first at rest. Here we can appreciate at rest and after injection. We notice two things: if there is any bubbles appear on the left side, and the timing, if it appears late or early. But here in the apical foot chamber, nothing appears ever in the left side. And we had to make sure that this test also performed with Valsalva maneuver to ensure if there is any shunt appear with Valsalva or increase the right atrial pressure. And here our pupil study showed no appearance at all of the pupil in the left side. So this patient had aortic coarctation by transthoracic echo. We excluded that if we got any kind of intracardiac or extracardiac shunts. In case of aortic coarctation, we need a CT. We need a CT to delineate the anatomy and the exact location of the aortic coarctation. And here we are noticed we started the CT. Let's go to our importance. We noted the RV is dilated, and here this is the sagittal view, which will appear the coarctation much better. And here our aortic segments, which appears, and this is a site of coarctation, which shows very tight coarctation segments against the subclavian. Here, which we have to differentiate if we got a totally interrupted arch or what's normal coarctation. The different only will vary in the management later on. At this stage, we got a patient of the aortic coarctation. This patient is the algorithm adopted from the EEC guideline. The patient has arterial hypertension, yes, and with peak-to-peak gradient more than 2 mm mercury, with the difference between the upper and lower limbs. But we notice here that the peak-to-peak gradient has to be measured through invasively through a cath. And the patient, or if we didn't give that, if we had a more than 50% narrowing in the aorta, the patient indicates for intervention. So in cases, this is the first dilemma in our patient. The patient has significant coarctation, the patient hypertensive for a long time, but also this patient had a significant pulmonary hypertension. So at this time, we had to, regarding the aortic coarctation, the plan is to measure the peak-to-peak gradient, and if it's significant, we got to intervene. In this case, we have to perform a stenting of the coarctation segment. And second time, regarding the coarctation, the pulmonary hypertension. So we got a significant pulmonary hypertension. Our theory, we had to frame it to which type of pulmonary hypertension we got. Our possibility that the patient had a pulmonary hypertension resulting from the increased blood pressure over a long period of time. This is causing elevated the left ventricular end diastolic pressure. This is the post-capillary pulmonary hypertension, or we got it's all coincidence, and this is irrelevant to her past history, and the patient had idiopathic pulmonary hypertension, or we can get something like a mix of both etiologies. We got a combined etiologies of pulmonary hypertension. So we first thing to do in this patient is right heart cath to measure the pulmonary pressure and to measure the gradients invasively. This is an algorithm of pulmonary hypertension. And this is the recommendation regarding what to do next. So class 1 recommendation to do right heart cath to support and the treatment decision. And we also, in this case, pulmonary hypertension has to have what is called vasoreactivity testing. Is if we suspect that this patient had idiopathic pulmonary hypertension, to detect patient who will benefit from high doses of calcium channel blocker. Vasoreactivity test is doing by giving the patient with in right heart cath nitric oxide or if we don't get nitric oxide here, we do it with oxygen. But I don't know if you agree with me or not. At this point, regarding the pulmonary hypertension, our colleagues suggested that we have to do cardiac MRI. Cardiac MRI for this patient was to detect if this patient has anything structure affection of her right side causing this significant amount of pulmonary hypertension. And so we proceeded to do CMR. CMR is perfect for tissue characterization and also structural delineation of anatomy. If this patient have like ARVC, non-compaction or whatever, pulmonary hypertension that can be explained by this. Is appear the CMR the parent or not?
Not.
Okay, give me a...
And while you're pulling the MRI, did you have a right heart cath done, or you guys just went to the MRI?
we went to see MRI first, and then we did when we performed afterwards a right heart cath.
Okay.
Here we can appreciate, I'll go fast, as the CMR didn't add much benefit. We got a markedly dilated right ventricle. CMR was specific. We has to answer to a little question. This patient has RV pathology or not? In the CMR, the patient has significant pulmonary hypertension. All signs of pulmonary hypertension were there. She has dilated main pulmonary artery more than 14 millimeters. The patient had D-shaped septum, heavily trabeculated RV. All this signifies secondary pulmonary hypertension. In the late gadolinium enhancement, which is more important, we got the LV insertion point enhancement, and this is also denotes that the patient has chronic pulmonary hypertension. No signs of infiltrative, inflammatory, or structural affection that's may signify any pathology of the right ventricle. So at this point, the add-on value of the CMR was that the patient didn't have any RV pathology that could explain that highly or rocket elevated pulmonary hypertension. So the next thing at this patient was that we need to perform a right heart cath. And let's give me a little moment. Back
So
to
in
our
the
presentation.
in the MRI, did you have any QP, QS calculated or gradient across the?
Yeah. QS for around 1.1, which is non-significant, no significant shunt across it.
And did you measure the the flow before and after the coarctation, or no?
No. We tried, but the technician took the images, we couldn't measure it accurately.
Okay.
Okay, so let's proceed. Here is the right heart cath. What we do, we test patient if they vasoreactive or not. Vasoreactive done with nitric oxide or epoprostenol. Or here in Egypt, we do it with oxygen O2, H2O2, due to lack of nitric oxide. And we also perform injection to see the pulmonary vasculature. Here in we can notice that markedly dilated pulmonary vessels and pulmonary vasculatures. And this is what we note from this right heart cath. We need to calculate the pressure, the right atrial pressure, the right ventricular systolic pressure, the mean pulmonary pressure, and the pulmonary capillary pressure to see where we lie in this case. We need to calculate the cardiac output and how severe is the pulmonary hypertension. Is the echo measurements is overestimated too much or not? And what about our filling pressure? Is this also elevated or not? Regarding our patient, we got our right atrial pressure with 22 millimeter mercury, right ventricular systolic pressure was like 64 millimeter mercury, and the mean pulmonary artery was rocket high. It was 83 millimeter mercury. And at this time, the pulmonary capillary pressure didn't seem much elevated. It was 13 millimeter mercury, and the pulmonary vascular resistance was like 9 volts. So that was the normal range of the right heart cath. Let's quick recap. This is the normal value. Right atrial pressure has to be below 5. Right ventricular systolic pressure has to be below 25 millimeter mercury, and the mean pulmonary pressure something like less than 25. And has to be measured invasively. Cardiac output has to be more than 5 liters per minute, and the cardiac is more than 2.4. Let's go back to our patient. This signifies we hear regarding pulmonary capillary pressure. It's not that elevated, but we got rocket shooting of the pulmonary pressure and the right ventricular systolic pressure and the right atrial pressure. This patient here could justify this. The major component of the pulmonary hypertension is idiopathic or pre-capillary pulmonary capillary pressure, which we suspected it would be markedly elevated more than that to cause that pulmonary hypertension. It wasn't that much elevated. So at this time, we had a discussion at the further management, future management of this patient. We got a plan to stent the coarctation segment and to treat the pulmonary hypertension as idiopathic pulmonary hypertension with the known guidelines, and we'll talk, give a brief notes afterwards about it. So we inserted radial and femoral sheath, and we got to snare the wire, stiff wire. We inserted through the femoral from the radial artery. Next thing, we have the injection, the coarctation segments. Here we can notice that the significantly stenotic segments, we almost get no flow. This is the site of the coarctation. Here it can be appeared better than before. And next thing, we have to put our stent. The stent has the stent length has to be this stent length. This stenotic segment in the echo and CT with around 24 millimeters. We picked here 38 millimeter stent to cover the pre and post what's called landing zone, and we are checking before implanting the stent. Here pre-implantation. And next thing, implantation of the stent. And we can notice after injection that we got our stenotic segment covered perfectly. We got a nice around it, and flow is almost going back to normal. So regarding coarctation, we did it with a coarctation stent. But what about the pulmonary hypertension? Regarding the pulmonary hypertension, this patient, first thing we thought a general measure throughout the course of the disease. This patient has cardiopulmonary comorbidities. This patient has significant hypertension. This has significant elevated end-diastolic pressure. We started this patient monotherapy or dual therapy. As for this patient, we started dual therapy, including ERA and phosphodiesterase inhibitor. And this patient just started 2 weeks ago, and we were supposed to see here after 2 months to see what she will respond regarding this treatment. So our take-home message is young hypertension, you should suspect secondary hypertension until proved otherwise. You have to look for careful clinical examination, blood pressure in the upper and lower limbs, and check for radiofemoral delay. If the patient has murmur is the key. Aortic coarctation causes systemic hypertension and LV strain. This leads to upper limb hypertension and LV hypertrophy. Family recognition prevents long-term complications. Pulmonary hypertension not explained by coarctation. Right heart cath is crucial to estimate pressure gradients across the coarctation, to assess LV afterload and pulmonary vascular resistance. This also prevents wrong assumptions and help individualized therapy and avoid misattribution. Dual pathology require multidisciplinary care, coarctation repair like what we did in our case regarding using a stent. And dedicated pulmonary hypertension evaluation requires parallel workup for causes and management. And lesson learned here, don't anchor on a single lesion. Always look for coexisting pathologies in young complex cases. 1.2 distinct disease processes, both influencing outcomes. Thank you for your listening.
Thank you so much, Dr. Ismail, for this great presentation. We really enjoyed it. Like, it's very interesting to have this coincidence between coarctation of aorta and at the same time we have pulmonary hypertension as well.
Thank you.
So I have a question about the right heart cath. Did we get like oxygen saturation and we get like any step up in the oxygen saturation in the right heart cath, or we didn't do that?
We did that. Two main concepts here we need to make sure of. Pressure across the gradient, or what we call transpulmonic gradients, and if we got a step up. The oxygen saturation, we performed the operation first at normal oxygen, 21% of oxygen, and then with 100% oxygen. We didn't get a step up at both at low oxygen or at 100% oxygen. This is third. Regarding transpulmonary gradient, if we got a significant difference between pre and post pulmonary, this is what we often sees in cases of supra or subvalvular PS. We didn't also get transpulmonary gradient. It almost like was the same before and after.
Okay, thank you so much. Any questions from our panelists, Dr. Sami, Dr. Ashley?
I have, so first of all, great presentation. I really like that you guys did every single modality, which is
Thank you.
good educational, but in real life, I'd say I have a couple of comments about that we really didn't need to go or to do all of this. Once she has coarctation, it seems like severe, symptomatic, just fix it. And then worry about the pulmonary hypertension later. So how long did it take for you to get all of the from the first encounter till she was fixed? That's my first question. Second is, do you have a follow-up? Like, how did this make her feel? Like, is her exercise capacity improved or not? Because you're blaming 2 lesions for her symptoms, right? So you're saying that she has severe coarctation, severe pulmonary hypertension. So now that you fixed one, you want to decide about like what's the next step. These are my 2 questions, and then I have a couple of comments about the imaging part.
Okay. Let's go to the first question. What the investigation take? Around 10 days. From the first presentation to the coarctation stent implantation, it took 10 days. The echo, the CMR, the right heart cath, the patient was admitted with hypertensive urgency. Her blood pressure was uncontrolled and low-dose triple therapy. So she was admitted, and we performed all this investigation, and then we proceeded to the right heart cath and the coarctation stent. Regarding the symptoms, we have 2 issues here. The hypertension, is it controlled? Usually this patient have to continue on antihypertensive therapies or meds after even putting the stent in the coarctation segment. But the patient did well in the follow-up. We can really, I would be biased if I say she's improved, but she reported improving of her symptoms and her functional capacity a little bit. She before admission to us or before presentation, she was almost have severely affected functional capacity by both culprits of her symptom. She wasn't doing any effort of any or anything something like that. She was household, but now she reported improving of her symptoms and her functional capacity.
Thank you. The comments that I have about the imaging is so first of all, great images. Like you got like really good windows for her echo, really good bubble study with Valsalva, and I wish to look for the loops and the right heart cath rather than numbers for the future. So, but it's overall, I think great images. If this is clinical patient like in front of me, I would have done a couple of things different. I would just jumped from abnormal pressures, upper and lower extremities, to CT, to just call interventionist and surgeon to manage her. The second is whenever we have these patients, we still worry about pulmonary hypertension, so we get sometimes pulmonary function testing before and after, and some genetic testing if there is any family history of problems can help you as well. Some pulmonary hypertension are related to certain abnormal genes. Not all treatable, but it would help for her offspring, especially that she's still young and trying to conceive. Medications, I think adjustments of blood pressure medications is a question as well that we still didn't sort out. Like if by the time you fix her, blood pressure hopefully will improve, so you're gonna have similar pressure. But if you have a patient with significant hypertension upper extremity but low blood pressure in the lower extremity, which blood pressure would you aim for? Like how low should you go? That's always a question, especially for borderline cases that you don't end up fixing. And we end up saying most of the time is whatever blood pressure that the patient can tolerate, doing activities without problems, even though if it's a little bit higher in the upper extremity, but that's what we would go with. But great presentation, and I really enjoyed it.
Thank you so much. That's a tricky question, and as you know, the lower the better. This is what the guideline says now. The lower the better, as much as the patient tolerated. That's the concept. We usually in the cases of we have different blood pressure, different variation. Both arms we measure for the upper one, and we take subsequent measures from the higher one, and that's what we're doing. If the patient is tolerating it well, we will up titrate to that control of her blood pressure according to the highest limb we got our measurement or our reading from.
Yeah, and sometimes you lower it too much, and if your legs get only 70 millimeter mercury while your upper extremity get like 130, 140, your legs will be weak while you're walking, and that's what we get into sometimes. But yes, it's patient symptoms and within reasonable numbers, I think is the way to go.
Yeah.
Yeah, I may add, like great presentation, very educational, multimodality, true. Yeah, maybe not everyone will do all the modalities, but I think each one of them is really teaching. I think when I go back into the case, right, like when you put the patient age, right, and age, and she's young, and think a little bit about femoral radial delay, and clinically we don't see that a lot, but I think coarctation, that's a classic teaching, right? But if the patient is older a little bit, you should think a little bit about severe aortic stenosis or aortic dissection or more vasculitis cases. But it's interesting, radial femoral delay is very classic teaching for coarctation. But if you think a little bit asymmetrical pulse delay between the two radials or the two femorals, that can be seen with large vessel vasculitis like Takayasu. I mean, doesn't apply for this patient, which is interesting. Now, and I think all the imaging was really awesome. And I think one of the things that really tells you from really the first snap you did in the abdominal aorta, the Doppler, if you don't have damned Doppler or signal in the aorta, in the Doppler of the aorta, that's probably an isolated coarctation, right? Because damped signal in the descending aorta means you may have concomitant PDA. But it's very interesting. Patient with coarctation, they may have single coarc, or maybe they have bicuspid or combined lesion, right? And now, if you are talking about coarc and pulmonary hypertension, if isolated coarctation, right, you usually don't have pulmonary hypertension unless really late in the case, when untreated coarctation will lead to left ventricular hypertrophy, diastolic dysfunction, left atrial hypertension, all of the above, and eventually post-capillary pulmonary hypertension. But this is not the case here, or maybe, but it's not that late. I don't think it's really what's happening here.
That's the bizarre about the patient. She is only 19.
Yeah, exactly. And then now I think what is important when you think about all of this multimodality, you're trying to think a little bit about, do we have a lesion that we don't find? Like, do we have a reason for that? Do you have a bicuspid aortic valve? Do you have an undiagnosed VSD, ASD, PDA, right? All of that, you really, each modality tells you, no, the bubble study was not that positive. Your QPQS is 1, all of that tells you, and even in the cath, right heart cath, you don't have a step up. So every single thing you are telling us, the coarctation is there, but there is other reason for the pulmonary hypertension. So I think this is kind of like really interesting to see. Like, if this patient is 40 years old, I will think, oh, maybe this is the coarctation. Now, one thing in my comment in the MRI, I think, maybe the good teaching here when you guys having a case like that, maybe spend some time with the tech to measure flow at the coarc and before the coarc and after the coarc. The reason your images show severe and too much collaterals, so you know that there's a lot of collaterals, and you will have a drop on the trans coarctation gradient. if you do that. So this is maybe something that you can go back to your tech or work a little bit in this for the next case, so you can have more better workflow there. The other thing also in the MRI value, to be honest, not a lot of people order MRI for pulmonary hypertension, but the value for CMR, you're gonna measure better the RV volumes, right? You can argue a little bit what your systolic, diastolic volumes and outcomes, and really the RVEF, what matters at this point. And if you have any late gadolinium enhancement in the septum, specifically focal RV insertion, right, which is very non-specific, but if someone with pulmonary hypertension and have a little bit of LGE or late gadolinium enhancement in the septum, that's carry poor prognosis. And I think that's really the value for CMR with contrast. Now, if you want to go fancy a little bit in the CMR, you can add 4D flow in the coarc. And we started seeing a lot of people doing valvular 4D flow and coarc and PDA, and the images are beautiful. So that's also something that you can add to your MRI lab. We don't do a lot of 4D flow here in the US, very certain people, but in adult congenital, 4D flow become interesting because the software become easier and the processing of that become better. So just FYI, but great case. I learned tons of things. So good job.
Thank you. Excellent comment. Thank you. Thank you, Doctor.
I have something also to comment about, like, if I'm not mistaken, these kind of patients will need infective endocarditis prophylaxis or not. I think these patients, according to the guidelines, if there is a congenital heart disease that was surgically corrected with a stent or something like that, they will need infective endocarditis prophylaxis in the long run. Is it correct, Dr. Ahmed Al-Ashri and Dr. Sami, if I'm not mistaken?
I believe it's only the first 6 months if you fixed it.
6. Okay, gotcha.
But it's most of the time actually we overdo it with prophylaxis, and we learned the lesson the opposite way. So we used to prophylaxis everyone, and then the guidelines changed like 7-8 years ago, said don't do prophylaxis for many people. But I believe it's only the first 6 months for a repaired congenital heart disease. If it's unrepaired, yes, lifelong.
Okay, gotcha. Any imaging on the brain, like any brain aneurysm?
No, the patient didn't have any symptoms suggestive of brain affection or neurological affection, so we didn't perform something like that. But regarding the endocarditis, it's here in Egypt we got high incidence of endocarditis. We see endocarditis like every hour. We almost give prophylactic antibiotics to this kind of patients.
Gotcha. All right. Any other questions?
Can I ask some logistic questions, just because I'm not so familiar with the university system, especially in Cairo. So I'm Ain Shams, and I believe Ain Shams is better than anyone else. But I'm kidding. So is this a self-pay patient, and how much would this cost if the patient is self-pay? And if we're doing this in a private institution, can this be really done all within 10
her a
days?
lot. It would cost her a lot. But regarding this patient, no. Given the young age of this patient and the dramatic presentation of her, she got all of her things done like in donations. She got donations for the CMR, donation for the stent, donation like for everything. Someone performed all that. Someone got things done. And one of our staff.
That's so nice. Yeah.
I'm glad that she got all of this, but is it really
Yeah.
necessary? That's the question, logistic question that I have in my mind, because it's a free hospital, I assume, right, or minimal cost for the patient.
Regarding the thing that what we do, what we can argue about is the CMR, but everything else, the CT is mandatory, the right heart cath also, and the stent I think she had to. CMR only the only debatable thing in this case, I think.
So who is reading the CMR? Like, is it the cardiologist or we have someone from the imaging doing that?
Dr.
Both.
Asfour, I assume.
Yeah, Dr. Asfour and Dr. Abdallah Laga. I'm working with Dr. Abdallah.
They are cardiologists, right?
Yeah, they are cardiologists and they have their own centers and they are working.
Okay, great.
No, but really great job, and we're very proud of that you can provide this service in a government hospital and with this high accuracy with really good results. I'll send you.
Thank
I'll send patients in your way.
I be my guest. Thank you.
Yeah, we have a question from Yusra.
Okay.
Everybody, good evening, everybody. First of all, it's a very, 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 very impressive presentation. I really appreciate the hard work that you have done. Excellent
Thank
images,
you.
a very, very good quality images, and it's an excellent teaching case. And for me, as an images, from the imaging team, I would appreciate that this is very, very hard work, and it needs a very good specialists in working like this. And but I have one question, two questions actually.
Okay.
Since you said in the history that she was pregnant and she just gave a birth to a baby before she starts presenting with headaches or something like this, how did her pregnancy went with this type of severe coarctation? And the second question that she will ask you when she will need to counsel for a second pregnancy. So
Pregnancy.
yes,
That's the first question she asked after
yeah,
after sent.
exactly. So how far you would go for her lowering her blood pressure, and for when will you consultate for a second pregnancy?
Thank you, Dr. Yusra. Very nice question. Regarding the first question, the patient had a pregnancy and uneventful pregnancy a year before a presentation. So her pregnancy went well, uneventful. They thought when she had hypertensive urgency, that's a gestational hypertension, and they performed all kind of investigation and they missed it. They diagnosed her with a hypertensive urgency. That's the first thing. But her pregnancy went well. The baby is fine. That's the first thing. Second question regarding this patient, I would recommend her against pregnancy in the future. I don't know, but part of this will depend on how she is performing the WHO classification from the pulmonary hypertension perspective of view. And regarding blood pressure, as in the latest guideline, the ILARA principle, as low as reasonably achievable, that's what we are adopting in the Cairo University. And that's what we are doing for this patient. She continued in her antihypertensive meds, and also she started ERA and phosphodiesterase inhibitor for pulmonary hypertension. That's also add-on effect. And that's what she had to be followed up regularly and close periods in our clinic. And till now, she's doing fine, and her symptoms much, much more improved.
Did you do are you planning to have another right heart case to measure her pulmonary hypertension and assess if it's regressed after the control of the coarctation? And that's I think that would be like the second type of pulmonary hypertension secondary to the left heart disease, and it should regress, or you're thinking something.
As to the right heart cath measurements, it was striking that that is not the culprit. The pulmonary capillary wedge pressure was something like 13. It wouldn't
Oh.
explain her symptoms. It must be another thing or another etiology. I didn't expect her to lower, the number wouldn't be lower, but first thing, the echo. The echo gave us a little lower number, but not what we expected. The first number was around 100, and follow up echo, estimated pulmonary systolic pressure was around 85, 84. So
Oh,
not that much of improvement.
not striking, yeah.
Yeah.
So you are gonna look for another cause?
We assume it's idiopathic pulmonary hypertension. It's a mere coincidence. It's
Yeah.
idiopathic.
Yeah.
Thank you for your question.
Yeah, I was thinking to ask this question about counseling, because as I know, like pregnancy will increase the risk for dissection for patients with coarctation of aorta. Like after fixing the lesion right now, I'm not sure if there is any specific guidelines talking about like the follow-up for these patients for dissection, if they are pregnant or something like that.
So if the patient with a congenital heart disease, a bicuspid aortic valve, a regular follow-up will be good, like every 1 year to see if there is enlargement in the dimension of the aortic root, if there is a significant aortic regurgitation or something like that. And regarding pulmonary hypertension, we follow up with their first thing with symptoms, the echo parameters, and to assess it regularly, and counseling would be better. And as a start, we recommend her against pregnancy, at least for the time being, and to see what's up next and how she will deal with this.
Thank you. Any other questions? All right. I think that was really great presentation. I really enjoyed it. And
Thanks,
I was
Dr.
like,
Ahmed. Very nice to meet you. Nice to
thank
meet
you
you
so
all.
much. Pleasure is mine. And me and دكتور سامح احنا كنا بقالنا فترة بنتكلم عن موضوع الرايت هارت كاث والموضوع في مصر، فدي حاجة بصراحة يعني تفرحنا إن إحنا نشوف الموضوع ده بدأ يتعمل أو بيتعمل في مصر دلوقتي، فده شيء كويس جدا. يعني هل الموضوع ده في ناس معينة في مصر يعني بتعمله، يعني جامعة القاهرة مثلا، أو الموضوع موجود في أماكن كتير؟ يعني أنا عن نفسي، أنا تجربتي إن أنا كان ليا حد قريبي كنت عايز نعمل له رايت هارت كات، والموضوع ما كانش سهل يعني. فمش عارف إيه الأماكن اللي ممكن نعمل فيها حاجة زي كده.
From Cairo University perspective view يعني أنا في تيم الكونجنتال
حلو.
وتيم الستراكشر heart disease. We
جميل.
had a regular list of hemodynamics. يعني every 2 weeks we perform a case of right heart cath. Usually بتبقى a case of congenital heart disease, either Menger, something like that. And even if it's not congenital, we do it. But we got a regular list of hemodynamics, right heart cath.
ده جميل جدا. طيب حلو. يعني ممكن دكتور سامي برضو يقول رأيه في الموضوع ده، ان احنا يعني على اللونج ران احنا محتاجين نكبر الموضوع ده شويه. انا حاسس ان هو يعني فيري ليميتد في مصر، موضوع الرايت هارت كات مش كتير.
Indeed.
يعني بالظبط. فمش عارف هو المشكله فين، يعني المشكله في الناس، ولا المشكله في الادوات نفسها؟
Both يعني like everything in Egypt the equipment itself is a big problem. Second, the concept, right heart cath, not like left heart cath. It's not rewarding in the let's talk frankly, in the private.
money
It's
wise.
not common. It's not common. Congenital itself is mostly quite in congenital cases, so it's not common practice. So it's not it's not common like the left heart cath. Left heart cath is the requested one, and so all people did left heart cath.
Yeah, I think the indication, like my time in Egypt, can mainly from their congenital group. They do hemodynamics all the time. I think this is the strongest, but also not much in the adult. You can see the adult in the structural heart, maybe, and shock, right? If someone have shock, hemodynamics is going to be very important. I think we talked about it before. I think the right approach maybe not just lectures. We can do lectures virtual, right, and right hard cath and stuff like that. But also, I think that kind of like we talk about workshops, like how and hemodynamics workshops, and that takes you from not just cath, and PV loops and echo hemodynamics. I think look at it as hemodynamics with imaging with echo mainly, and of course right heart cath. And you can go from not just right heart cath for pulmonary hypertension and congenital, but the whole concept also with shock. But I'm not sure that's going to need a little bit of industry support, and we can arrange that and we can help with that. And you have models, and you have and really you don't need really there's a lot of models that can be automated, and you can simulators for that may help. So I'm not sure if anything happened in Egypt like that or not. I see a lot of presentation, a lot of conferences with cases, and all of that is great, but I think you need hands-on people do it by themselves.
Yeah,
And I
exactly.
think that's going to be different. And I think
Yes.
if we can do something like that, then it'd be great. And we have we have a group of a heart failure team that really willing to come and do that, and we can brainstorm with this. Yeah, but I think maybe attached to a conference, attached to a meeting, have the main people from university come and do it. Maybe people can proctor people doing the right heart cath in the lab itself. All of that can be done, but also just we need to understand what the bandwidth, the timeline, all of that. Yeah, happy to help regard whatever, because I think the need is there. So
Yeah, indeed.
واعتقد ممكن يعني الموضوع ده يتحقق في مثلا موضوع في مؤتمر كبير في مصر بيتم، انا نسيت الاسم والله، بيحصل دايما في اسكندريه، كارديو اليكس تقريبا او حاجه زي كده.
Cardiacs. Yeah.
تمام. ممكن مثلا حاجه زي كده يبقى في ورك شوب بس للهيموداينامكس والرايت هارت كات وحاجه زي كده، ونبقى احنا مثلا دكتور سامي والجروب الخاص بيه الهارت فيلير ممكن مثلا نشارك في الموضوع ده ويبقى فيه كولابوريشن. يعني دي جاست ثوت، يعني حاجه جت في دماغي دلوقتي قلت اقولها يعني.
yeah,
مش عارف.
all of that is fine, but also يعني يعني what's needed, right? I think
مهم.
and what's allowed in the conferences, right? We can speak to the people who are running this conferences and see if they have a bandwidth. But at the end of the day, they're gonna come to what industry willing to bring in, right?
But
And how.
I know Dr. Mahmoud. He's Dr. Mahmoud, and he's so much supportive. And if you give him such an idea, I think he will adopt it. He's
Yeah,
such a
let's
supportive
brainstorm.
guy.
Yeah.
He is a
Yeah.
much supportive guy. I know him personally. He will like something like that.
Yeah, why not? And I think, if you bring a little bit angle of right heart cath and hemodynamics and congenital heart disease and shock and structural heart disease, then you can bring people from the cath itself. You can bring people from structural stuff and also the shock stuff, because it's really well needed. Yeah, so if you guys think about a couple of conferences that maybe can be a good venue, and then we'll start thinking and talking to people about it, I think that will help. So,
Okay, I'm planning on it.
yeah. I think let's be something that we do in 2026, right?
Okay.
Or maybe 2027, hopefully the next year or two. I think attach any workshop with a big conference, it's gonna fly because people can do it. And yeah, we got you the right people to do it too. So from here, because a lot of people want to do it. So
Okay, I'm looking forward for it.
yeah.
شكرا جزيلا دكتور سامي. سؤال في دكتور إيهاب بيسأل سؤال عن ال VQ scan to evaluate for CTEF.
Yeah, we did it, but to not get the whole that we did it to search if we got a perfusion mismatch, but we didn't. It was nothing for
Okay.
mismatch, so excluded
Okay.
stuff.
Exclude. Okay. Got it. All right. Any questions? Anything else you want to discuss?
I just have a question about what was the first lighting point that directed the workup for the aortic coarctation, like just the physical, the signs you have in the physical examination, or was something else? And was you worked up for any secondary causes of hypertension, or was the first thing was aortic coarctation that you worked up for?
What guided us or shed a light was the radiofemoral delay. It was a
Oh,
significant. It was a radiofemoral delay that I haven't seen almost since my first year in the residency. It was a clinical textbook case. Second thing, the elephant in the room. We got secondary hypertension, we got aortic coarctation, and we got hypertension. So we didn't search for another cause. It may be, but we didn't search for another cause of, we got a clear culprit in front of us, so we didn't.
great. Okay, great. Yeah, I think that's like shows how important the physical exam and to consider like not just doing it just routinely. You have to like think about it and do it the right way. Thank you
Yeah,
so much for
exactly.
sharing. Yeah.
You're welcome. Thank you.
Thank you so much, Dr. Sami, Dr. Nashri, Dr. Ghazali, and everyone who attended this really, really nice session. And thank you, big thank you to Ahmed Ismail for this great presentation. It was
Thank
really
you.
pleasure to know you.
Thank you for
And
having me. The pleasure is always mine. Thank you, Dr. Ahmed. It's very nice to
we
meet
are
you.
we are very proud of you. Like
Thank you.
that's really great.
Thank
Yeah.
you.
All right. We hope that we see you again and again. And I think
I
like
hope
that.
so.
Yeah. So anyone has any comments before we close?
I would like to thank everybody who attended today, including our panelists, Dr. Abu Zaid, Dr. Nashri, and Dr. Azali. Thank you so much, Dr. Ismail, for your presentation, your case,
You're always
and
welcome.
hope
Thank
to
you,
see you
Dr.
in the
Khaled.
future. I
Hope so.
still like still announcing for our donation for the campaign for the grant for the match season this cycle. I hope everybody can like join us, and with a very, very simple participation will be very helpful, and it can be helpful even if you just share it and let other people know about it. We really appreciate all the attendance, and thank you so much, and thank you so much, Dr. Ahmed Ali, for your help.
I appreciate it. Thank you.
Bye.
Assalamu alaikum.
Bye-bye.
Thanks.
Bye bye.